Allison mentioned it, this issue of cabotegravir alone as a prevention, so an injectable prevention. Julie, what do you think that might have? What benefit, risk, how might that fit into the kind of prevention world that we talked about way back an hour ago or so?
Yeah, I mean, I think in some ways there are parallels with treatment, with stigma issues, and also with questions around, is it going to solve some problems around adherence and then create others? And I think there's also a question of what kind of impact it's going to have in terms of overall prevention impact. So if you think about, let's say the only people who are interested in long-acting PrEP are people who are already taking daily PrEP and they switch, it's really not going to have any population-level effectiveness. So what we're hoping for is that long-acting PrEP will cater to some chunk of the PrEP market that's not interested in taking daily PrEP, but is interested in taking long-acting PrEP.
Though, again, this is a thing that's talked about a lot, this issue of people who start on oral PrEP, so they say they're ready for oral PrEP, but then they don't persist. And that's a population that could get benefit from injectable, don't you think? Or
yeah, it depends what their barriers to persistence are, right? If their barriers are that they don't want to be coming into the clinic every 3 months, long-acting may not help them because they may have to come in even more.
Right, sure. Yeah, if their barriers they forget.
That's right, then it could be perfect.
Then it could be perfect. The other groups that I'm worried about are kind of people that are in unequal power relationships, or in maybe commercial sex work or some other situations where they just can't afford, either because of bodily risk or emotional risk, to have a pill, in their hands or in their drawer or wherever,
or their pills get stolen because they're homeless.
Right.
Yeah, I think there are populations for whom long-acting PrEP could be really useful, and people who don't have power, and then also, in addition to homelessness, people who inject drugs who may have a difficult time taking a pill every day, but may be coming into a syringe exchange frequently.
Right, or methadone maintenance,
that's right.
or buprenorphine.
So I think thinking about how to co-locate them could be really powerful.
Sure.
I think there's a stigma of having that blue pill that you take every day. People assume that you are positive or what have you, and so there's some risk to even taking PrEP, right, in certain communities. So I actually think it's about expanding options in an armamentarium, and for different people or the same person at different times, a different modality may work for them. And so, it's that even for treatment, you may be taking it, and then you have to go abroad for 2 months, and maybe that's the time to get your shot, right? Yep. And then so you don't have to worry about taking your pills to Morocco or what have you, right? So it's about choice and options, and it's exciting to have them. And I think we are going to have to work out the systems issues, the administration issues, and the opportunities to have more people at the table. We're not the only ones that need to give shots. Don't have me give a shot. The nurse, the pharmacist. How do we make our practices work for people? How do we go to them and give them their shot? I mean, how do we think about how to increase access and get over those barriers?
One thing you hear about PrEP a lot is to, quote, non-medicalize it.
Exactly.
What that means exactly.
Demedicalize it.
Demedicalize it.
You got all the terms.
Really? Tell an aging brain. I mean, that's important, right?
Yeah, that's huge. I think it's, when we first introduced PrEP, it was highly medicalized, and I think that's kind of stuck. And actually, PrEP care is more intensive than HIV care at this point.
Yeah, I know. It's kind of weird, isn't it?
I mean, these are healthy people taking a very safe, effective medication.
And it is important to point out that we actually don't know that this injectable is going to work. It's being studied.
Correct.
There are at least 2 large randomized trials, one in predominantly men who have sex with men and transgender women, and another in high-risk women in Africa, that are exploring a comparison between injectable and pills. An active control, which would be the TDF-FTC. So I think that's important.
Yes.
We've discussed it a lot. We're excited about it,
Yes.
but we don't quite know yet whether it's going to work. But some of these really long-acting alternatives could also make a difference that Allison mentioned.
Absolutely.
And potentially for therapy too.
Exactly.
Though probably we have to find, for therapy, we have to find partners. We probably have to have 2 drugs that have similar durations of activity in order to put them together.
I mean, I think we may be talking about, you know, an antiretroviral and a monoclonal antibody. I mean, I think we're entering a new phase, I think, and which is, again, exciting, not to overuse the word.